So now let's take some 2-3 slides of abnormal gestational sac. Now, what is an abnormal gestational sac? Now see, most valuable is that if it is abnormal size, distorted in shape. Abnormal in size means I am expecting a 6 weeks gestational sac, MSD. I am as per this LMP. So MSD, mean sac diameter, is not 6. What I am expecting as per LMP is 4. That is abnormal size. Now I am expecting an oval or a round gestational sac, and all of a sudden I am seeing distorted shape, especially the pointing edge, which we will discuss. So on your distorted shape, then thin decidual reactions, 2.5 is the cut. If I am seeing 1, then it is abnormal. If I am seeing 1.5, that is abnormal. If I am seeing maybe a 2, I will think why it is only 2, but it can be normal. But if it is 2.5 and 3 and 4, then it is absolutely normal. So 2 is the cut. So weak decidual reactions and low in the endometrial cavity, not located in fundus body, but somewhere low, near isthmus. Maybe it is already in the cervix. So a low lying gestational sac is also abnormal. Now see here, it is not in fundus, it is not in body, it is somewhere at the level of isthmus, if not in the this cervical cavity. So low in position, weak decidual reactions, distorted in shape and small in size. So next is very important thing, the oligoamniotic sac. What is an oligoamniotic sac? Oligoamniotic sac, the term itself, that something is getting small, and that is the amniotic sac, that is the fluid. So how to make out whether I am dealing with this mean sac diameter? When you are taking CRL, for example, first you are expecting, as per LMP, you are expecting an 8 weeks fetus. The CRL is corresponding with 8 weeks, maybe 7.5, maybe 7, but anyhow it is corresponding with this, whatever I am expecting. Don't see to this picture. I am expecting an 8 weeks fetus and my CRL is corresponding with some plus minuses, but it is corresponding. But the gestational sac is not corresponding with 8 weeks, is much less, maybe 5, maybe 4. That should knock your door. Please get up. When a guest is knocking on the door, you are getting up. Who is there? So same way, it should knock your door. Why I am seeing a CRL as per my expectation, but why not I am seeing a gestational sac what I am expecting? Why gestational sac is very less than CRL? This is the point. Now something should knock your door to get you move. So this is the thing here. When the crown rump length CRL is matching with your expectations, but the mean sac diameter, I am using word mean. How to take that? We will discuss in practicals. Mean sac diameter will not correspond, will be less. Now, then you will measure it. Then, first, this was the knock on the door. Now you will measure it, whether you should open your door or not. Then you are seeing through some hole that who is there. This is the thing. Then you will measure it. CRL, for example, in this case was 12, 1 to 12. 12. I will put CRL here. And the sac, mean sac diameter is 15, 15. Oligoamniotic sac, mean sac diameter minus CRL. So I have to take CRL from the mean sac diameter. So I will take 12 from 15. If I will take 12 from 15, that will be 3 in this case. If it is 3, this is less than 5 millimeters, and this is a confirmed case of oligoamniotic sac. Please note this. MSD minus CRL is equal to or less than is equal to less than. Even 5 can be labeled as this oligoamniotic sac, and if it is less than 5, then yes, it is for sure abnormal, and that is oligoamniotic sac. Let it be. Why should I waste my time in discussing this oligoamniotic sac? It is there, let it be. But you will not let it be there, because there was a study conducted by the Brawley in which 16 patients between 6 to 9 with oligoamniotic sac had 15 abortions. It means that 15 sacs were lost from 16. So more than 90%. More than 90% of oligoamniotic sacs will be lost. So now there is a patient who is in India, has to go to US, day after tomorrow, you will not allow her. Now, you are now knowing why. Because 90% is the chance that she will abort. And you will not make patient happy, is not going to US. You will not make patient happy that there is a fetal pole. Now you will not make happy the patient by showing the fetal heart, but you will alert the patient and the consultant, whosoever has sent you patient, or if you are the same person who is treating the patient, you will get on your toes. Now you will rescan the patient, and you will put your everything in action to treat this. How to treat that, that is not our topic, but now you will label this as oligoamniotic sac. And 90%, remember, oligoamniotic sacs are lost. So, abnormal gestational sac criteria on TAS, whenever you are not seeing a double disc dual sign, when the sac is more than 10 millimeters, it means that if it is more than 10 millimeters on TS, you should see it, and the impossibility to detect the yolk sac when the sac is in between 20 is for this transabdominal, and 8 is for TVS, which we will discuss in detail. That is why I am not giving much of time over here. So when a growth rate fails, so this is also abnormal, which we will discuss in detail. So take care. This was the first session of this early pregnancy. We will continue with this early pregnancy in next session. So now we are starting the second session of early pregnancy with subchorionic hemorrhage. Now see this bleed, whenever seen, it can be at the level of placentation. It can be at the level of placentation. This chorionic frontosome, which we have discussed, and we will talk more about this. Now, if it is at the level of placentation, it can lead to the placental separation and will lead to the abruption. But the hematomas, if detaching the membranes only, will unlikely reach to a significant volume to affect the normal development. Now, these hematomas should be seen in relationship to the trophoblastic tissue. How? We will discuss this. Now, how can I make out what is the point? How can I make out whether I am dealing with a bleed which is at the level of the placentation or away from placentation? This is my point. If I will be able to, I am talking of early pregnancy, while it is a bit challenging to say where the placentation is. Now, if, for example, I am seeing this thickness over here, this thickness itself means that this is a developing placenta over here. But here I am having a grown up fetus over here, that is why I am seeing this developing placenta. But the point in case of very early pregnancy, it is a bit difficult to make out. But if we know some tricks, we can make it out. Now this is a small gestational sac over here. This is the small gestational sac over here. Now this small gestational sac is having the decidual reaction around it. This is the decidual reaction. This is the decidual reaction. This is the decidual reaction. And I am seeing a hazy decidual reaction at this point. But the point is, am I seeing a thick decidual reaction at this point and thin here? Yes. I saw a thick decidual reaction. It automatically means that I am dealing with a chorionic frontosome, which is nothing but the developing placenta. And if any hematoma at that point will be labeled as the hematoma at the level of placentation. This is a very important point. I am not seeing here a placenta in itself, but I am seeing a thick decidual reaction, and the thick decidual reaction will give me an idea where the placenta is developing. And now see this bleed over here, this bleed is away from this site. What site is this? A thick decidual reaction, which is the site of placentation. Now this is a hematoma which is not detaching the placenta but detaching the membranes only. Now if this thing would have been here, it is much away, from the placentation if this thing would have been somewhere here. But if this point, this hematoma would have located somewhere here, this would definitely be labeled at the level of placentation. So C for this thick decidual reaction, and that is nothing but the chorionic frontosome. Now next is the yolk sac. Now this yolk sac, I am giving the only example of a tiffin over here, because this will make you to understand very important points. This is a God's given tiffin to baby till placenta takes on its function. God is giving a tiffin, take my boy and go to the world. This is the God's given tiffin to a baby till placenta takes its function. Now, God has given a tiffin and has put a lock on that tiffin. Baby has come with a tiffin, but there is a lock on that tiffin. Baby is not able to open the lunch box, tiffin box. What will be the outcome? He will die of hunger. Now God has given a tiffin with a food, but a contaminated food. Baby will eat, will not be healthy, maybe that he will die. And God, due to some reason, has given a tiffin with no food. God has given the tiffin, but there is no food. Baby is opening the tiffin, but there is no food. He is dying because of hunger. These are the 3 points which I will elaborate. Tiffin with contaminated food, tiffin with a lock on it, and tiffin with no food in it. So this yolk sac is a tiffin to baby till the placenta takes on its function. Now on ultrasound, how it will look like? It will look like a jet black like this, jet black, a round, not oval, a round structure with anechoic lumen, and the walls are bright. But the point is not wall over here for this point of time, but the lumen, which is jet and jet black only. Now, as already said, that this is responsible for the transfer of nutrients to embryo. Now, if you want to know about the growth of the yolk sac, that is 0.01 millimeter per millimeter of growth of the mean sac diameter. And the yolk sac is in between 5 to 6 millimeters in 5 to 6 weeks. So on an average, it is 5 to 6 millimeters in bracket of 5 to 10 weeks. Now this is the graph representing the yolk sac diameter. Now see here, I can make out that it is not going and crossing the 5, but at the same time, it should not dip below 2. This is the point here. It should not be less than 2 millimeters, but it should not be more than 5 millimeters. Now, if I see a yolk sac, I am not dealing with a pseudogestational sac. I am not dealing with a Nabatean cyst. I am not dealing with a decidual cyst. So it confirms me that whatever I am seeing is nothing but an intrauterine pregnancy. So this is the first structure which is visualized inside sac if the sac is intrauterine. So if you see a yolk sac, the ectopic is ruled out. So as already said, that this is the first structure which is located in the gestational sac. And the next is, it diagnoses the embryonic demise. Please try to understand how. How this structure is diagnosing me the embryonic demise. Now, I am seeing a fetal pulsation-like thing. It can be transmitted pulsations from uterine artery. I am not very much sure. I am not sure that whether I am seeing true fetal pulsations or transmitted pulsations from maternal side. Why not to go to the tiffin and see whether tiffin is normal, and if tiffin is not at all there, how the baby is surviving then? And if there is a lock on the tiffin, there are high possibilities that you are dealing with transmitted pulsations, not of the original these fetal pulsations what you are supposed to see. So you see an abnormal, very abnormal, I am using this word very severely abnormal yolk sac. Severely, not just abnormal, severely abnormal yolk sac, which we will discuss in next slides. Severely abnormal yolk sacs is a sign that whatever you are seeing is not a live fetus but a dead fetus. Then ask yourself whether you are dealing with transmitted pulsations or true fetal pulsation. Please count the number, how many beats are there, and if it is about 60 to 70, put a hand on the maternal pulsations and it will correspond to 66, and the maternal heart is beating at 66, and if the fetal pulsations are 66, then it is sure that you are dealing with the transmitted pulsations, not the fetal one. So here, what is knocking the door? This yolk sac, severely abnormal yolk sac is telling me, oh, doctor, you are getting cheated. See, please. Then I will see on these lines and I will come to know that yes, it is true. It is a dead fetus what I am dealing with. So it predicts the outcome. It predicts the outcome. Again, a patient is here and from India she has to move to China or Thailand or anywhere. with an abnormal yolk sac, I will not allow. So that way, if the patient is having a normal fetus today with normal fetal pulsations but an abnormal yolk sac, it means that I cannot predict whether that fetus tomorrow or a day after tomorrow will be live. So this way, it is predicting the outcome of this pregnancy. For example, I am having a calcified yolk sac. Calcified yolk sac. Calcified yolk sac means that I am having calcifications all around the yolk sac. I am not having just this wall. I am having a calcified wall. It means that God has given a tiffin but has put a lock on that tiffin. I should ask myself that why this fetus is live. And if the fetus is live today, there are high possibilities that it will be no more live tomorrow or a day after tomorrow. And most of cases, if not in all, a calcified, a severely calcified yolk sac will be a dead fetus today only. So, yolk sac assessment to the spontaneous abortion prediction. If it is too large, don't think that God has given him a big tiffin. No, this is abnormal. This is abnormal. It should not cross 6. I gave you the graph. It should not go beyond 5. In between 5 to 6, it is borderline. And anything above 5, it is too large. So that is abnormal, and the specificity is 97% and the positive predictive value of 66%. And if it is too small, less than 2 millimeters, again, this is an abnormal sign. Please see to the fetus. Maybe that the fetus is not pulsating today, and even if the fetus is live today, there are high chances that he will be aborting very soon. Now see here, I am seeing like a sac in a sac. I am seeing a sac like a sac structure in this sac over here. This is not the second sac, but the yolk sac, which is very much enlarged here, and this can be more than 6 millimeters, and in this case maybe that this is already touched 10. So don't get happy that you are having a patient with a very big tiffin. No, this is abnormal. And here, this is the yolk sac over here, which on measurement was less than 2 millimeters. And again, this is abnormal. So measure the yolk sac, measure, because too small is having a specificity of 97%, positive predictive value of 44% for the assessment of the spontaneous abortion predictions. So I told you that the yolk sac is around and around only, not even it can be accepted not even if it is oval, it has to be round. And if it loses its shape, it is irregular, especially these wrinkled indentation from these walls, the irregular shape indentation from the walls will be considered very much abnormal. Then the degenerative changes. What I mean by degenerative change here, there is abundant calcifications and decreased translucency. Now this decreased translucency means that I told you it should be jet black, but due to any reason, there are some echoes in it, small particles like thing in it. Will you expect it to be jet black? No, it will have a grease shade now. So that is the tiffin having a contaminated food. If the translucency is going not from not now jet black, but going from black to some grease shade, so it should be jet black. Any echoes in it is not accepted, and if there are some echoes, it means that some contaminated food has been put over there by God. So it is just to make you understand and to so that you can remember. I am giving this example of this tiffin and the God. Now number of yolk sacs. If you see one yolk sac, most probably you are dealing with one fetus, most probably. But if you see two yolk sacs and only one fetus, please make a thorough search. Maybe that you are getting a second fetus also. And in most of cases, yes, you will get a second fetus also, most of cases. So number should be equal, the number of the yolk sacs should be equal to the number of fetuses. Now putting in one slide, normal and the abnormal yolk sac. The size is 5 to 6 millimeters up to 9 weeks. Abnormal is less than 2 and more than 6. And shape is round and round only. Anything oval or distorted will not be accepted. And USG findings are hypoechoic center. It is not hypoechoic, it is jet black. Why I am using word hypoechoic here? Because I am comparing it with the next structure. What is here? Here is wall. Wall is very much reflective, echogenic, and the center should be jet black, not hypoechoic, because the hypoechoic here is the comparison anechoic. So hypoechoic center in comparison with this wall. So wall will be jet, this whitish shade, that is echogenic rim with a jet black center. You can take like this. And if I am seeing a hyperechoic lumen, that is very much abnormal. That is not a contaminated food now. That means that God has put a brick or a stone in the tiffin. So if I'll be able to put Doppler, there is absence of diastolic flow. There is absence of diastolic flow. And if I am making out any blood flow, especially in this diastole, I am making out any diastole. What it means? It means that the congestion has occurred over there. It is not very easy to take it. You have to make a lot of adjustments, but with time you will gain the experience and you will be able to put the Doppler. That is why I am giving you at this point of time. If you are seeing a diastolic flow, it means that congestion has occurred over there, which is very abnormal, and in normal there should be no diastolic flow in the Doppler investigation of this yolk sac. So this was all about the yolk sac. So the moral is that please see to the yolk sac. Yolk sac is a mirror. Yolk sac is a guide. Yolk sac is mirror. Like for example, you are seeing a contaminated food. For example, you are seeing a hyperechoic, not a jet black one, no, a hyperechoic lumen. So that is telling you that doctor, please look to it. I am not having a food, I am having a stone in it. So most probably you are dealing with a dead fetus. If not dead today, there are very high possibilities that that fetus will be no more live tomorrow. And you are seeing no yolk sac at all. It does not mean that there is not a yolk sac at that particular time. Maybe that there is a very small 0.5 millimeters already regressed, that the ultrasound is not picking it. That is also possible. You are not seeing a yolk sac. Ask yourself why this fetus is normal, why this is beating. Okay, this is beating. He had some food maybe yesterday and he is alive till now because of that food, and tomorrow you will not expect that fetus to be live. So this is a guide of mine and a track wherefrom I can make out many things. So make a habit to scan the yolk sac, especially for its size, for the contours, and for the echogenicity of the center. And if you will be able to put a Doppler on it, there should be no diastolic flow in it. So now the embryo and the fetal cardiac activity. Please make a note over here that each and every fetus is live. It does not mean that the fetal pulsations are not present today and will abruptly come day after tomorrow when you will rescan. Each and every normal fetus without pulsations are having, if it is live, are having pulsations. It is you who are not able to see it. It does not mean that fetal pulsations are not present today That is the reason you are putting a query and advising the patient to rescan. So don't think that fetal pulsations are not there. They are there since beginning. So in fact, my teacher told me that he is no more now. He told me that it is the first thing which can be seen even before the visualization of an embryonic disc. What is embryonic disc? Embryonic disc is a very small fetal pole. Embryonic disc. It is visualized on ultrasound even before visualization of embryonic disc. Why? Because this is in motion and there will be scattering from that area where there is fetal heart. Now, if I can apply whole of my physics there, I can even see in a fetus which is not visualized of its own. So the point is not that you have to go to that depth. The point is that it is there, and there only. Now you have to make first all attempts to see it. Please, whatever physics you are knowing, apply it. For example, what you have to do? You have to adjust with the depth first. Before depth, you have to adjust with the transducer's frequency, which is the first pro, which is discussed with you. That you have to decrease your frequency, you have to increase your frequency. If you are increasing your frequency, your resolution is improving. Then the depth, adjust the depth. Why to scan with the 12 centimeters depth? If the target, if the target is at 2, so adjust the depth, and adjust the gain, and whenever needed, adjust the TGCs of that specific area wherever you need it, and adjust the PRF. So with these things only, and see from all planes. One plane may not show you anything, but a multi-slice may show you this fetal pulsation. So with this physics, you can make out that in most of your rescans, there will be no more rescans left. So this is the point when you are labeling a fetus with no cardiac activity today. So now you have got the cardiac activity, you have to see how much is the cardiac activity. Why? Because not only cardiac activity, how much is the fetal heart beating today, that is very important. And if the heart rate is less than 80 beats per minute, less than 80 beats, I have to correlate first. It with the CRL. I have to correlate this with CRL. For example, here the CRL, if the fetus is having 80 beats, less than 80 beats, and the CRL is less than 5. Now see, it has to be correlated with the CRL. It is having a high embryonic demise. Now, the fetal heart is in between 80 to 90. 60% is the risk. 60% is the risk. If the fetal heart is 80 beats and less, and CRL is 5. So more than half will be lost. More than half. So again, you will alert the patient that it is not completely abnormal. And now see, as the heart rate is increasing from 90 to 99, the risk is decreasing, but still the risk is there. It is 32%. Even it is 100, the risk is there, but has dropped up to 11 now. Now the point is, with increase of the fetal heart, the risk is dropping. With a 5 millimeter CRL, I should expect more than 100. More than 100, lesser the heart rate, more the risk of demise. So now, more than 100 is considered normal with CRL of 5. Now the CRL is not 5. CRL is from 5 to 9. If it is from 5 to 9, the heart rate of 100 is abnormal. Even 105 and 110 is abnormal. So with a CRL of 5 to 9, the heart rate should be 120 and above. So now see, we are correlating. We have to correlate it with CRL. Less than, now see, fetus is having a heartbeat of 110. 110 is normal if the CRL is 5, but abnormal for the CRL of 7. So I have to correlate it with CRL. So with increasing CRL, the heart rate is also increasing, and with dip in the this fetal heart, the risk of demise is increasing. So, for example, here it is 10 to 15. A1 with 110 is associated with poor prognosis. So you can take that 5 less than 5 millimeters. It should be CRL. I mean, it should be more than 100, and in between 5 to 9, it should be about a 120, not 105, 107. That will be normal if the CRL is less than 5. Now, you all know what is a missed abortion. Missed means that there is no fetal heart activity. There is no activity from this fetal heart. Now, if I am in doubt whether fetal heart is there or not, why not go to the Tiffin and see whether the Tiffin has having anything? What I can make out here, that I am not having fetal heart, but my Tiffin is having a lock on it. Now this is the calcified wall. Now see, I am having here less of lumen, more of wall. Now this is the calcified yolk sac, giving me an indication that the fetus is already dead. And the point is, even if it is not dead today, for sure, it will be dead tomorrow. So I will alert the patient and I will report this. If I am seeing a fetal heart, most probably I will be having a less of fetal cardiac activity not corresponding with CRL. So if I will report the things, maybe that I will save a life. Maybe that I am dealing with a very precious pregnancy. And by labeling these things normal, the consultant will not take care of the fetus, and day after tomorrow, the patient will have bleeding PV, and on rescan, we will say that day before yesterday all was okay, and today there is no fetus, and you have missed your fetus. And don't do these things. Try to make out the use of the Tiffin and the CRL in this case. For example, the fetal yolk sac is telling me that something is abnormal. If not now, it is abnormal. Please do take care of that. So blighted ovums and embryonic pregnancy, it means that there is no embryo in it. There is no embryo. So a blighted ovum, here the causes are mostly these chromosomal abnormalities. So we'll not spend much of time here because nothing to discuss. We are having a this gestational sac over here. We don't have any fetus, and the cut is 20, 2020. You are not seeing anything. Anything I mean that you are not seeing a fetus. You are seeing only the gestational sac with a measurement of 20 and more. And most probably you will be seeing a thin residual reaction, and the cut is, as already said, that 2 millimeters of residual reaction should be there at least, and I am seeing 1 only. So then I will not hesitate to label this as blighted ovum. And most probably it will not be having its normal shape. Maybe some irregularities from the shape is there also, and yes, we can see these irregularities from the shapes also. I will not show you much of slides. As already said, that more slides are what you will do. You will copy those slides in your mind and you will search for those in your patients, and you will not see those. It will vary from patient to patient. So better is to generate an image from your mind what you should see in a particular case. So even if you want to see it, don't copy it, take an idea. So here what I am seeing a gestational sac. Now see, I don't see any fetal pole over here, and here there are some echoes in it, and on the top I am seeing no fetal pole over here, and here I don't see any fetal pole. And if I will take measurement, I will take measurements to demonstrate that I am dealing with a gestational sac of more than 20 millimeters with no. Now see here, I am not making out the decidual reactions even from the top. Why I am saying top? Because here the beam is struck by 90 degree, and if I am missing from the top, I will not expect it to come from the sidewise, because the best angle striker, even the best angle striker is not showing me any this dual reactions. Dual reactions will look like this. Now see here, I am having dual reactions. These are the dual reactions. So here complete dual reactions are normal, but the fetus itself is missing. This will be also labeled as embryonic pregnancy because of the missing fetus and the size of the sac. But here I am having not only size appropriate to label it, but the dual reactions will look like hyperechoic ring like thing here, and I am missing it here, not even from the top. And if I am seeing this irregular gestational sac, this is very abnormal, and if size corresponds, I will label it as an embryonic pregnancy, that is blighted ovum. So now the decisions how to make in the early pregnancy. First of all, I have to see whether the embryo is there or not. So try to please try to draw this graph. Now first, if I have seen an embryo, first question to ask is whether cardiac activity is there or not. Then if present, what is the status of yolk sac? Is yolk sac normal? Okay, yolk sac is normal. I will not leave. I will see to next. And what is that? What is the heart rate? Now see, not only one thing, I have to see multiple things. Not only visualization of the fetus and the fetal pulsation should make me happy. So I have to see yolk sac. I have to see how much the heart is beating. Then I have to correlate with CRL. I have to correlate it with CRL. Then only it can be labeled as normal. Now, everything was normal from the top. I saw an intrauterine sac. I saw an embryo. I saw a cardiac activity. It is present. What usually is done up to this point only, but I forget to see the yolk sac. Now from today onwards, I will see to the yolk sac. Now if yolk sac absent, what it means? Where is the Tiffin? Maybe it is very small. So with this much of small, which is not resolved by the ultrasound, why this is normal? If this is normal today, it cannot be normal tomorrow. So see to the yolk sac. If absent, please follow the patient and report this case. Okay, it is not absent, but is abnormal. What I mean by abnormal? It is not round, it is not jet black, it is very small or very large. Okay, it is present there, it is not large, but walls are calcified, also abnormal. This is what it means. Yolk sac abnormal. So absent means absent, we have to follow it, but here abnormal means that it was present but abnormal. Again, I will report and I will follow this case. Okay, yolk sac is normal. Fetus is visualized, fetal pole is visualized, yolk sac is normal, but I will not get happy on seeing to the heart rates only, heart pulsations only. I will see how much is the heart rate, and the cut is already given, the graph is already given to you, how much it should be and how to correlate it with the CRL. It is less. Now see, tachycardia is not a worrisome, but here worrisome is more this bradycardia. So this is abnormal. Abnormal means that this is decreased. again I will follow that why this is decreased. So this way we have to take the decision. The cardiac activity absent, but make a note, make a point, it is not absent, it is non-visualized. So don't report that cardiac activity is absent. Please put your physics in work. Then you will see in more than 70, if not 80%, that I am sure, if you will put your physics in more than 70-80% of patients, you will get the fetal cardiac activity. Condition 2, you will put your physics in action and see to this cardiac activity. So anyhow, it is absent. Now absent is a wrong word here. It is not visualized. I am giving a cut. This is a cut, not this is not a cut in itself. It is the benefit of doubt. This is for you that you are not able to see it. 5. So if it is more than 5, and you are confirmed that you have put your physics in action. Physics, all physics. Before putting the color, to see for this color from this, that will hardly make any sense here. Because what is color? People are thinking we will put color and we should see a fetal heart. Color is nothing but a superimposed color on a gray scale. Please try to understand this. If the fetal heart is here and my scan plane is away from the heart. Now see, this is heart. I am cutting here, not here. Now see, if I will put the color, I should put color on a beating thing, then I will see to it. I am putting color, I will not see anything. I should cut the scan, this plane through the heart, then I have to put color. Now color is not making any sense here to say you that you have to put color. If you will be putting color on this beating heart, now if you are already seeing with grayscale, what is the fun of putting color? So color is just to demonstrate yourself that whatever you are seeing is heart only. And with your naked eyes, you can see on the screen if the scan plane is going through the heart, and just to demonstrate on the patient, and we will not recommend you to put the color in very early pregnancy. So anyhow, the way is this, and if it is less than 5, you can follow up. So why? Because maybe that there is some benefit of doubt for this late conceptions. So this is the way you have to make out a decision in a very early, early pregnancy, first trimester scan. So this is the way you have to think and shake these neurons before taking any decision. You can pause the video at this point of time to draw this decision making diagram. So this is all about the first trimester, which we have started, but this is not the end of the first trimester. This is just a beginning, which we will discuss in great detail in our coming sessions. Thank you very much.